and gentlemen, good afternoon, dear panelists, your excellencies. I'm delighted that you have come to discuss health at these development days. And that's important because if you read the document, the consensus document, you will find as paragraph 27 the following: health is central to people's lives and is a key element of equitable and sustainable growth and development, including poverty eradication. And you will see that that paragraph also affirms the right to health. It affirms the commitment to universal health coverage and to health in all policies. And these are issues, of course, that we are going to touch on as we discuss and as we get input from our distinguished panelists. You've heard it frequently, but I think it's important to say it again, that, and it reflects the morning or the lunchtime opening session, I should say, with all the political dignitaries and political leaders, that health is a political choice. It's truly a political choice whether we decrease health inequalities, whether we invest in universal health coverage, or whether we address the commercial determinants of health. And it's that political dimension of action, and which implies political courage, and it implies a certain amount of passion. This is something I think you will hear from our panelists. You will have seen anyhow what a wonderfully gender-balanced panel this is. So we're very happy about that. We have with us Dr. Tedros, who is the DG-elect of the WHO. And this is one of the first important occasions where he is reaching out to other sectors beyond health to give the health message. We have Commissioner Andriukaitis with us, who is responsible for the health and food safety portfolio, and will share with us the elements how health policy is an essential component of the European social model. So again, a very, very intersectoral challenge. We have Dr. Diane Gambusha with us. She is the Minister of Health of the government of the Republic of Rwanda. And I might add, before she became Minister of Health, was the Minister of Gender and Family Promotion. And I'm sure she took many of those issues with her as a priority as a health minister. We then have Dr. Ala Murabit, who is a medical doctor and a UN high-level commissioner on health, employment, and economic growth. And again, this is this intersectoral message. Health contributes to economic growth in a range of ways. And one that we have neglected is actually the workforce itself as an economic factor. And again, if I might make the gender point, since about 80% of the workforce in the health sector is female, this has enormous ramifications. And finally, we have Ms. Kalaba Nkonde with us. You know that there is a Young Leaders program here, and she represents the young leaders. She's currently studying a master in public health, pharmacy, and hospital management, but perhaps for our discussions here, even more importantly, is engaged on the ground in organizing HIV/AIDS campaigns and is particularly interested in partnerships and public-private partnerships. So you can see what a distinguished panel this is, and that's on the one hand that all speakers here are health professionals, but all of them have moved out of their sphere of comfort, if I can say that, to be political actors for health, to be advocates for health. And that brings to mind, I'm German, and one of the most famous quotes in health, medicine, and public health comes from Rudolf Virchow, one of the famous founders of social medicine, who said politics is medicine at large. And it's about a better society, it's about well-being. And this is what we'll be discussing at this panel, because that's what SDG 3 is about. It's about people's health and well-being. And we'll give it that special focus in relation to inequality between countries, within countries, but even more so in relation to people on the move. Because people don't stay anymore within their boundaries, within the boundaries of what we call the nation state. And that gives us a totally new perspective also of the right to health and the access to health care. I'd like to give the floor first to Dr. Tedros, who has been a very strong advocate for universal health coverage as a Minister of Health, but also a very strong advocate of health during his term as Minister of Foreign Affairs. And the strategy of the African Union setting its goals for the development of Africa, I would say, includes a very strong health component, last not least, because he was the chair of that commission and was able to convince the other policymakers that this should be the case. Universal health coverage, next to a number of other issues, is the priority of his campaign, is the priority now, I think, of his office. And I'm delighted that you're here, Dr. Tedros, and the floor is yours.
Thank you. Yeah, good afternoon. The house is, I think, full. Thank you, Ilona, for that introduction, very generous introduction. I will add to that politics is medicine at large, and to that I will add political intervention, actually surgical intervention. For transformation, we need politics. That's why we're really advocating for politics to have a big part in what we are aspiring to achieve in the global health arena. Ladies and gentlemen, it's really great pleasure for me to be here today with you at the European Development Days, focusing on investment in development. It's encouraging to see many world leaders have gathered here to discuss investment in the 5 Ps: people, planet, prosperity, peace, and partnership, enshrined in the Sustainable Development Agenda, placing health at the center of global agenda. As you know, from next month onward, I will be honored to lead the World Health Organization. In this task, my dream is to see a world where everyone can lead healthy and productive lives, regardless of who they are or where they live. As you know, we have a commitment to leave no one behind in our SDGs. For I firmly believe that health is a fundamental right. When I signed up for 5 years at the head of WHO on May 23, I committed to the principle that ensuring enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, without distinction of race, religion, political belief, economic, or social condition. Health is also a foundation for global prosperity and security in the 21st century. As many of you know, accelerating the growing international movement for universal health coverage will be my #1 priority as Director General. The world stands at a unique moment to drive progress on universal health coverage. There is now both compelling technical evidence that universal health coverage is achievable and high-level political momentum to translate that consensus into change. I will be helped in my task by the fact that the current Director General, Dr. Margaret Chan, my sister, has been such a vocal champion of universal health coverage for this I will be grateful. In all the debates around the formulation of the Sustainable Development Goals, it became increasingly clear that good health is both an outcome and also a means to development. There is more and more agreement that health belongs fair and square at the center of the global development agenda. Moreover, health is one of the smartest investments we can make. Hundreds of leading economists, including 5 Nobel laureates, identified universal health coverage as an essential pillar of sustainable development, citing that every $1 spent on health yields up to $20 in full income growth within a generation. WHO, as the UN leading agency on health, has a key role to play in helping take forward the 2030 Agenda in an integrated and coordinated way. Working with partners at country, regional, and global level, WHO can help governments achieve better health, addressing all determinants: economic, social, environmental, as well as commercial. Over the years, I have been more and more encouraged to see stronger partnerships evolving around the critical importance of health in the commitments at the G7, G20, in the UN family, on my home continent of Africa within the African Union, and here in the European Union. The European Union is clearly a hugely important partner. I have seen that in my own country as health minister and foreign minister, and also as a good partner to the World Health Organization. And that's why my first visit is to the European Union. I look forward to collaborating closely both within Europe and globally. As Commissioner Mimica indicated, the new European consensus on development is the European Union's response to an increasingly interconnected and challenging world. We should build on each other's strengths to achieve this, both globally as well as on the ground. I would also like to remind you that next year, we mark the 40th anniversary of the historic Alma-Ata Declaration on Primary Health Care. A strong primary health care focused on health promotion and prevention can meet the vast majority of people's health needs from birth through old age, protection against infections, care for illness, and prevention of non-communicable diseases focused on risk factors. In addition, primary healthcare workers are the front lines of detecting and stopping health emergencies before they become global crises. Alma-Ata was born in Europe. It's fitting that we should work together to make its ambitious goal of health for all a reality. When I take up the position of Director General at the beginning of July, I look forward to outlining to you my goals. In the meantime, however, I'm pleased to be with you, listen to you, and share ideas in order to ensure the best possible working relationships over the next 5 years. I'm looking forward to my collaboration with Susanna Jacob, my sister, the regional WHO regional director, to benefiting from her experience. Above all, I look forward to working with you to improve health of people in Europe and beyond over the next 5 years. I thank you.
Thank you very much, Dr. Tedros, and thank you also for that offer of dialogue, because it is always this exchange that takes us forward, and we would actually hope that next time around at the International European Development Days, we have a much stronger health contingent, because somehow the sectors aren't quite as aligned yet as we would like them to be. Often people say, yes, we're all for health, but when it comes down to it, they're not there. And I understand it was quite a fight, actually, to get health into the consensus document. I can say that as a moderator. So I'm very pleased to give the floor now to Commissioner Andriukaitis. We met a couple of weeks ago at the G20 Health Ministers meeting, and there the very first Health Ministers meeting, which shows how important health is in the political arena. You might not know that the Commissioner was a very, very active politician in his country. He actually co-authored the Lithuanian constitution. And this political acumen that is necessary to move health forward, I think also helps us in this context. Please, Commissioner.
Thank you, dear Ilona. Ladies and gentlemen, dear Dr. Tedros, colleagues, it's a great pleasure to participate in this panel on reducing inequalities. And when I hear word inequalities, I feel very, very bad. Can you imagine 21st century? And we are dealing with those terrible words, inequalities. I saw those inequalities when I was in Liberia, Guinea, and Sierra Leone in time of Ebola crisis. Mamma mia. It's real inequalities. But first, I would like to congratulate Dr. Tedros on his appointment. I wish him very big and every success. The Commission stands ready to cooperate closely with you and support WHO's leadership in global health. Leadership, we need to understand this word leadership. And we need to see WHO as leader fighting inequalities. From my first days as a doctor, I always ask myself, do I understand what does it mean, a health? And thanks to WHO, a health is social, physical, and mental well-being, not merely disease or infirmities. Can you imagine? Well-being. And of course, sometimes when I'm speaking about health, we are immediately speaking about health care and cure. No, first of all, we'll draw attention on such well-being and complexity. Because I am very proud that in Lisbon Treaty we have 4 excellent words: human health, public health, medical services, and medical care and cure. And when we are speaking of human health, we must keep a holistic approach on well-being. And here, environmental, social, cultural, and behavioral determinants play very big role damaging our health. Financial crisis also shows how it is painful to see that today inequalities are rising between countries, people, and continents. People with higher education, better jobs, and higher income enjoy better health. Of course, and of course, behave a healthier ways and live longer than those from disadvantaged populational groups. And this is very painful. And while poorer people face more health problems, they often cannot afford also health care, not only health. Right here in Europe, poorer people are 10 times more likely to suffer unmet medical needs for financial resources than affluent people. Of course, they are under big pressure of risk factors. They use less quality food. They smoke a lot. They drink a lot. They are not ready to care about themselves because they are understanding it. And this creates a lot of problems with daily health and health care also. And also, almost 1 in 5 women with a low educational level perceive their health as a bad or very bad compared with less than 4% of more educated women. This social gradient is everywhere in both developed and underdeveloped countries and developing countries. And this is why for the Commission, reducing health inequalities is a horizontal approach, horizontal objective of our health policy and developing policy, of our work with EU member states and developing countries. And you mentioned, my colleague, you mentioned 5P. brilliant piece. And I would like to add 4: prevention, promotion, protection, and participation. But participation of all of us, of all actors, because we need to understand health in all political sectors. If we are not ready to cooperate, coordinate, and improve our capacities act in all sectors, then we will be empty words. Why so difficult? We all know how it's very difficult to say health is value in itself. Okay. But if you look at reality and to see how to improve health conditions, living conditions of poorest people, then you see how it is difficult to do it. And this is about health. We need to redouble our efforts to meet our sustainable development goals, to ensure healthy lives and promote well-being for all worldwide. And it's our big obligation. Otherwise, people don't believe in our promises and don't believe in WHO and don't believe in Sustainable Development Goals because we failed with Millennium Goals. We need to move forward and understand how it's important today to discuss those development issues. Otherwise, it's a really challenging time for us. Health is for all. Doesn't matter, rich or poor, educated or not, unemployed or employed. Health is a right. And this is why the Commission has recently proposed that European Union countries endorse a statement on the social rights of Europeans, a right which includes only timely access to affordable, preventative, and curative health care of good quality. We call it our pillar of social rights. We have fully reflected this in our development cooperation policy too. The EU is a strong promoter of sustainable development targets of universal health coverage. And we need to find practical ways of ensuring that everybody has access to the most basic care, including vaccination, as well as to clean water and sanitation everywhere. I saw in those countries how it's important to understand that basics, they need to have minimum basic standards. And we know how it is difficult to introduce it. Without this, universal access remains empty words. To help tackle inequalities here in Europe, later this year, the Commission and Member States will launch a joint action on health inequalities to help tackle the social determinants of health across policies. And in EU, it is not so easy to do it, but can you imagine how it's difficult to do it in Africa, in Asia, also in South American countries. But we need to move forward. In addition, several departments are working together to support the most vulnerable groups in EU, such as the Roma community and newly arriving migrants, to leave on one behind when it comes to health and healthcare. We are right now improving our knowledge on inequalities in the European Union through a process called State of Health in the EU. We must address these social determinants and inequalities in everything we do, from fighting risk factors, tobacco, for example, to encouraging healthier diets, to promoting universal access to care. Let me give you an example. 8 out of 10 smokers live in low-income countries. Can you imagine? Which are already afflicted by so many problems. Plus, both in Europe and in developing countries, tobacco robs families of income and raises their healthcare costs, further fueling a vicious circle of poverty, poor health, and poor living conditions. So, to address inequalities, we need to tackle risk factors, especially tobacco, and vice versa. The inequalities and social determinants angle needs to be embedded in everything we do. Ladies and gentlemen, inequality are a pressing global challenge. For example, income inequality between countries remain high and has even increased within countries over the last 2 decades, especially in period of economic crisis. There is a long way to go to achieve our target of zero poverty. Can you imagine? Zero poverty till 2030. And we will do it. We will think about it. Such inequalities can hamper growth, macroeconomic stability, poverty reduction, and health. Last year, the Commission proposed in its European Consensus on Development that eradicating poverty, tackling discrimination and inequalities, leaving no one behind remain at the heart of EU policies. The EU is right now supporting 17 countries with bilateral health programs worth 1.3 billion euros. And is spending a further 1.3 billion euros through global initiatives. Nevertheless, total health expenditure in low and middle income countries falls far below the necessary minimum spending per person per year needed to provide basic life-saving services as accepted by the WHO and the World Bank, 60 euros. In 16 West African countries, the median per capita government health expenditure was 42 dollars in 2014. In the 3 countries most affected of Ebola, health expenditure was even lower. Poorer countries will require sustained health sector support to reach even the recommended minimum figure. Leaving no one behind is central to EU development cooperation policy, so the Commission is contributing to improving coordination, resource allocation, and aid effectiveness, particularly for those countries that are most vulnerable to disease outbreaks. We need to ensure that the resources are effectively coordinated and aligned with country planning cycles and systems, how services should be provided and financed, and the role of the private and public sector must be determined by the partnership in each country. We support the WHO at regional and country level to engage I2I as co-facilitator and coordinator with partners governments through our Universal Health Coverage Partnership Program, which with some 61 million euros today. In addition, the International Partnership for Universal Health Coverage 2030, launched at the World Health Assembly last month, requires strong cooperation across health, social and financial sector. To succeed, the European Commission will continue to act at all levels, using the tools at its disposal to help reduce health inequalities in Europe, but worldwide, and especially in those countries which today are under big pressure after such terrible economic crisis. Thank you, colleagues.
Thank you very much, Commissioner, and thank you for reinforcing, first of all, the commitment of the European Union to address inequalities worldwide, but also highlighting that the SDGs are for all countries and that there are many inequality issues that need to be addressed in this part of the world as well. Dr. Susanna Jakob, the Regional Director for WHO of Europe, is here, and she has made this one of her priorities to address the inequalities here. And thank you also for mentioning the need of health in all policies to move this forward. I read a quote recently by Dr. Tedros where he said, "Nobody should die because they are poor." And I would like to ask Her Excellency Minister Gashumba, who has been a strong advocate for access to health in her country and beyond, to share some experiences with us. How can you approach that in your country? How have you moved this forward on your own, together with your head of state, together with other ministries? How do you address inequalities?
Yeah, in Rwanda, today we are proud of the achievement we've made in the health sector. I would talk about the good coverage in immunization program. We are today at 94% of immunization coverage. We are today at 91% of deliveries at health facilities. And we have a health insurance that is covering 90% of the population of Rwanda. And the government is subsidizing the biggest component of this health insurance. But we came from far. We came from far, and I want to share the experience. I want to take you some years back, before 1994, where in Rwanda there was no insurance. there was no health insurance. And this is a tradition of inequity in health services, in health program, because you can understand in a country where there is no health insurance, the only people who can access to health services are the ones with means. And in Rwanda, before 1994, there was a gender imbalance. Women didn't have any word to say, even on the reproductive health, on the choice of spacing, on the choice of a number of kids to have. So there was this gender imbalance. Also, there was an inequality in distribution of health facilities. You could find, for example, 10 hospitals or 5 hospitals in one region, and in another region, nothing. So this shows you that before 1994, we were very far from MDG's achievement. And how did we get there? We've got there because of a strong leadership, a leadership that is really focusing on the population, the citizen, without any discrimination. And after 1994, we saw a change in the constitution. And today, our constitution is catering for justice, equity, and accessibility to opportunity, equal access to opportunity for everybody, regardless where you were born, regardless your family, how your family is, regardless anything else. And the government of Rwanda and all politics and policies are really catering for all Rwandans. And today we have community health workers that are working at the ground level, and that those are 3 people per 100 household, and they have been trained for health promotion. Their first role, their main task is sensitization of the population. So they work closely with the health facilities, and it's 3 trained people per 100 household that can treat diarrhea, they can test and treat malaria, and they can treat moderate pneumonia. And those community health workers, this homegrown solution has really contributed to the achievement of the MDGs, especially in reducing the maternal and newborn mortality. We have also today mapped the needs in terms of health facilities, and today we have health facilities at different levels of administrative level of the country. So every Rwandan, wherever he is, can get the level of health services he needs, regardless of northern province or southern province. We have similar politics, we have similar protocols, we follow the same guideline, and to reach out to the few people who are not accessing to health services because we are not at 100%, and the government is much concerned about the few people who can't be reached by routine programs like the routine vaccination or the delivery at a health facility. That we have interventions, punctual interventions that bring all Rwandans together, but with much focus, with the concern on the most vulnerable. I can give you an example of the health, the maternal and child weeks we organize twice a year. We have the Army Week that is bringing together the Army, the police, and all citizens in different sectors to go and reach out to people in remote areas. For example, currently there is an Army Week that is happening, and that is contributing to surgical interventions in remote areas, bringing specialists, doctors specialists in different fields from the private sector, from the public sector, to go and look at those people who can't reach teaching hospitals or other specialized services. Another intervention I can mention is the performance contract. There is this accountability system in Rwanda where we set up goals with regard to global politics like SDGs. So we set up indicators, and we domesticate those indicators according to the needs in the country, according to the local context, and everybody follows these indicators and is accountable. So we sign performance contract with our supervisors, with the population, and we have to achieve those goals. We have to work toward the performance contract we are signing. Thank you.
Thank you very much, Madam Minister, and thank you for highlighting a couple of really important things. First of all, building a system, and a system that's accessible to all and that is financially accessible also, as you've indicated, ensuring accountability and involving the whole of society, as you have explained with the health days, and always keeping this view on the most vulnerable. Dr. Tedros, you also, just like in Rwanda, when you were health minister, you focused on community health workers. Can you just give us one or two examples also from that experience? Because it seems that if one invests in these workers within a reasonably short time frame, one can get significant results, as we've seen in Rwanda also.
Yeah. No, first of all, I mean, the opportunity in Ethiopia was, there was a very strong government commitment. So the political leadership was ready and agreed to have universal health coverage. And we discussed on how to phase it. And the government decided to start it with primary health care. And we even compared some models, and we came up with ambitious plan to achieve blanket coverage or achieving universal primary health care in 6 years. And we didn't have even resources when we planned that. But we put the resource mobilization part of the plan. Even resource may not be a limiting factor if there is commitment. And by the way, the same applies in other countries. Countries who are not wealthy, because of political commitment, they have achieved universal health coverage. One very good example is Sri Lanka. Cancer treatment is actually covered by the government, which is very expensive. So that kind of political leadership was key. And the other thing is, when you talk about primary health care or at large, you know, the services, unless you understand the part which is excluded or not using the service, you cannot achieve universal. So in our assessment, we found out that women were not underutilizing the services. And children are dependent on women, so children were also underutilizing the services. And that's why the idea of all women health extension workers came during our discussion. And by design, we actually started training all women health extension workers that could be deployed in the rural communities to serve women. Because the reason for underutilization was cultural problem. As you know, in social exclusion is because of inequitable distribution of power. And that inequitable distribution of power expresses itself in economic, political, social, and cultural dimension. And the underutilization of services by women in Ethiopia was because of cultural reasons, cultural taboo. They don't normally seek services from men service providers, especially in rural communities. So you have to break that. That's why women health extension workers were trained and deployed, and the service use increased. So when we talk about coverage then, it's not the physical presence of an institution. You have to also look at the barriers, like Minister Gashimba was saying. You should break the financial barriers, the cultural barriers, and you have to even understand why there is exclusion of a certain group from accessing the services. I think that was what you said also. There was, from the start, political understanding of the situation. And political solution came into play in support of the technical solution, which is training of the health extension workers, that was implemented. So this was the experience, which really helps, especially if there is political leadership. and that without undermining, of course, the technical intervention also you do, and the political supporting the technical intervention.
Thank you, Dr. Tedros. Dr. Murabit, I think this flows very nicely into the issues that I was going to ask you. What are the key benefits of a more balanced representation of women in the health sector? And particularly, what can be done to allow women also to participate in a whole number of ways? You've also founded an organization, the Voices of Libyan Women, where you have made this a goal. So how to best address these gender imbalances in the community, towards the professionals, with the professionals, and what's the benefit also of looking at women as health professionals in a slightly different way?
Hello? Can you guys hear me?
Yes.
Okay, great. I know it's after lunch, so if you guys said you couldn't hear me, I would just assume that you had fallen asleep. No, so I get to wear 3 hats. I am a doctor by training. I am a UN Sustainable Development Goal Global Advocate, which means I get to see health and its intersection with all of the other goals and its interdependence with all of the other goals, and a UN High-Level Commissioner, where I focus a lot more on really the economic and medical nexus and how that really works. And in all 3 of those spaces, there is one thing that's very definitive, and that is that there are women in healthcare. I mean, they're actually the vast majority of healthcare providers. They're just not necessarily viewed with as much importance or given as much space, and their voices are not amplified as such. And that's often because they're your nurses, they're doulas, they're midwives, etc. So that's one of the key areas that we're looking at. But across the board, what we've seen is that traditionally health has been seen as an investment with no return economically. Governments have for a long time seen it as we just keep putting money into health. Universal health care means you're paying a lot of money and you're not getting anything out of it. Now, what makes this interesting is there are companies, many here in Europe, but around the world, that will actually pay their employees more to stay healthy, because they know that their employees are able to come to work more days. They take less sick days. They're more alert. They're more effective. They end up being a lot happier at work, and they're more committed to the company's goals. So a lot of research began to delve into this, saying, listen, if that's how it works for employees at a company, then that's probably how it works with citizens in a state. And if healthcare is provided, then citizens are more likely to go to work, to get an education, to be more beneficial, more contributing, more economically sustainable members of society. And that's without even looking at the benefits of wellness in general. That's without looking at how health intersects with food security and the fact that we're actually looking at a society that can be a lot more sustainable in that way. It's without looking at urbanization and the impact that health and wellness can have on urbanization. It's simply looking at the fact that economically, health becomes one of the greatest stimulants in a country. Now, when we look specifically at women, we already know that the education of girls will increase the GDP by 2 to 3% if 10% of the girls in that country are educated. I come from a country where 75% of my graduating class was women. There was a lot more women in STEM than there was men. But that doesn't translate into employment. And we have to start talking about the social limitations that actually disallow for women to engage in employment spaces, particularly in health. That means looking at infrastructure. It means looking at the security of hospitals. The fact that many hospitals are not in areas that are in city centers or close to places where they can get to without secure transport. It means looking at security in the sense of, can you be there overnight? Can you leave at 3 a.m. safely to go to the hospital and to work? Or is the hospital closer to a military base than it is to a center where it actually serves a population? So those are important questions we need to ask. We then also need to start talking about the fact that we tend not to recognize women's leadership in health, but we also tend to minimize the impact and the benefit that minorities and refugees and migrants can have in health. One of the greatest challenges, I think, now, given the current situation, is ensuring that people who are no longer in their home country are able to practice and perform out of their home country. And that means we have to look at things like licensing, and we have to start talking about ensuring that people can have means of income and actually be able to work. So if a doctor was a doctor in Ethiopia or Libya and decides to come here, we need to simplify the way in which they can actually engage and operate within this health system. We also need to talk about the fact that we just don't have enough healthcare professionals. In some parts of the world, you're looking at one doctor per every 20,000 in the population. That is not sufficient. It's unrealistic. And it's not realistic that we're going to be able to import enough doctors to actually serve those populations. So what we can be doing is investing more in things like telehealth and e-health, which allow for us to reach other populations. And this is specifically important for women. In countries like Pakistan, where there's been an incredible movement for telehealth that has been driven solely by female doctors who have OBS and gynae appointments over the phone and are able to get pictures sent to them and received from communities that would never, from women in communities that would never be able to come into central cities to actually get the feedback and the necessary information they need. So I mean, there's, you know, when we talk about health, I think my greatest frustration is we talk about health in a silo. And we say, you know, this is medicine, you know, you have a surgeon, you have your practitioners, et cetera, some nurses. The WHO will come in when maybe there's an infectious disease. That's when people mention health. That's when people mention health institutions without recognizing that the WHO is as responsible for infectious disease as it is for mental health, as it is for food and water security, as it is for education, because they're all intersected. And unless we can get health out of a room where only health practitioners are interested in it, then I don't think we're really going to make much change in it. We have to start talking about it within the larger spectrum of the Sustainable Development Goals. Thank you.
Thank you very much. A very strong message. And a strong message, I think, also to all the heads of state that were here this morning, that health is a significant part of the development agenda that they have set for their countries. I'd like to turn to a woman leader, a young leader, Ms. Kabala Nkombe from Zambia. And she's really working on the coalface, as we say. She's working in the community. She tries to establish public-private partnerships in the healthcare sector. How do these partnerships help address the most vulnerable people? Can you share your experience with us on that?
Okay, thank you. Firstly, I'd just like to congratulate Dr. Tedros on his election. As a young African woman who's also a healthcare professional, we're looking forward to engaging with you and seeing how you're going to engage with the youth during your term. I'd also like to start by saying the shortcomings when it comes to public healthcare sector has been well documented. It's been all over the place, and its inadequacies has forced a lot of people to try and seek their healthcare services in the private sector. But they cannot afford this, which further puts them into poverty. And then it increases the burden on the public healthcare system now. And then you have a lot of healthcare workers who are frustrated, apathetic, and don't have the zeal to actually do their job. And this hinders the services that government is supposed to give to their people and achieve universal health coverage, because you're not giving quality healthcare services. But for me, the primary issue is we know that government can't do this alone. So the best place that we can look to now is partnering with the private sector, whether it's providing incentives to private pharmaceutical companies to try and reduce their medicine costs, or if it's looking to leveraging and engaging with private hospitals and entities about sharing their technology and their systems, as well as their strategies on how to run an efficient system. All this is key in the government providing universal health coverage and access to health services to the most vulnerable people. How many of us actually think about the situation we are in if we were to be in dire need of medical services? It's a very easy answer. We probably have medical insurance. But for some people in the most remote of places and the places where I work, with our organization, these people actually have to think about how long is it going to take me to get to the hospital? Is there a hospital in my vicinity? Can I afford actually the services that I'm going to get to the hospital? All these issues are key in determining if a person is able to access healthcare services. So the take home from this panel that we're actually having now and the debate is that us as healthcare professionals, it's our duty, it's our responsibility to do whatever we can and to our utmost ability to be able to provide universal health coverage to all the communities, especially the most vulnerable, because the people's needs come first, and that's the way we can achieve SDG 3 by the allotted time. Thank you.
Thank you. Can I follow up here? Yes, please. Can I follow up here with the Minister? How do you approach these public-private partnerships in Rwanda? What experiences have you had?
Yeah, thank you. In Rwanda, we are promoting the private sector, and we are seeing this trend of the private sector coming in and investing in the public health sector. We have now private hospitals that are really linking with the public hospitals by bringing in the skills and the specialties they do have and maybe that can't be found in public sector. We do have also external partnership that are coming from outside the country, and as you know, Rwanda is among the first countries where doing business is very easy, and with the zero tolerance on corruption, we are seeing these days a huge trend of private sector coming to invest in Rwanda in many sectors, but we are welcoming this PPP, this public-private partnership in health sector very much because we have a shortage of specialists in the public sector, and it is a great opportunity whenever we see private people coming to invest in the lab, in creative, and even in prevention sector in Rwanda.
Thank you. Commissioner, can I also ask you, you mentioned the SDG agenda, the breadth actually of SDG 3, and only being able to be successful if we bring in many different sectors of government and of society. How will the Commission help move that kind of SDG thinking forward? We have, the Development Compact now, which is a great step, having the Parliament, the Commission, and the countries. But it means, a constant dialogue, a constant moving forward. What do you think is really needed at this stage? We had the signing. What now, particularly, should the health community do to move partnerships forward?
Absolutely. Sometimes it is very easy to sign declarations, but it's very difficult to introduce those declarations in real practice. And today, in EU, we decided, okay, all member states have their obligation because they approved Sustainable Development Goals. And they are obliged to introduce Sustainable Development Goals within countries, together with EU and outside. And the first big area is their obligations, and then we have good opportunity to measure situation, to see indicators, and to see how we are moving in direction, keeping eyes on our obligation and time frame. Second, we have good opportunity to use our institutional instruments, and EU is a good example for all of us around the world. We have councils, we have European Parliament and Commission. We signed our so-called paper, the consensus paper. It means that all formations, they are obliged in their agenda, keep their obligations high on top, and discuss every year, and of course also keep eyes on presidency country, which is obliged to coordinate situation, and of course use their instruments, providing and their own support to third countries, and of course keeping eyes on sustainable development goals. Third question is, we have good cooperation with Susanna Jakob, with you, with WHO, with United Nations, and we are biggest, not only donors, but we are biggest global leaders to trigger, to raise those questions. You know, today, very important statement about very strange step, go out of Paris Agreement. But EU shows the crystal clear position, because Paris Agreement is also about health, no doubt. And we say very clearly that we are ready to create, to build worldwide coalition, asking African countries, Asia's, and of course to be together and to move forward, introducing our steps which were signed and agreed. Of course, it is also important we have our internal mechanism, we have our agencies. We have good possibilities to cooperate through agencies, through laboratories, ECDC, EMA, and of course together with WHO agencies, and to create possibility to create added value as EU and as member states separately. And I think this is only one way we will show today, especially today. It's very important to show a really leadership of EU and all countries to press very much on worldwide actors and to use G7, use G20, and of course keep eyes on our obligations, and of course ask all actors to fulfill their obligations every year. And it's especially very important today to see how to, in frame of reforms at WHO level, of course also fulfill our obligations to put money into programs. Otherwise, friends, about what we are speaking then? We will send today messages that the financial obligations of every partners today is crucial. Look at of course, World Bank and they know very well what does it mean to have enough financial resources. You know, sometimes excellent wars, sometimes they're empty wars, without possibilities to cover these wars with human resources, financial resources, coordinating mechanisms, and also tools and obligations and measurement of our progress.
Thank you very much. I think I'd like to follow up with Dr. Tedros here on particularly this issue of financing. You highlighted in your campaign that you also felt that there needs to be a different approach to financing. The SDGs, of course, also say that in highlighting the domestic finance responsibilities. And therefore there's a kind of ambivalence. On the one hand, the push for the 0.7 for all countries. On the other hand, the push for domestic investment, particularly also in health. And then, of course, the financing of our common global public goods agencies like the World Health Organization and others. So would you say a word or two how in this SDG era we approach financing in a more complex way, and particularly the financing of health?
Yeah, this is a very important question. 2015 was a very historic year. We had the Addis Ababa Action Agenda, and we agreed on the financing mechanisms for the Sustainable Development Goals, Paris Agreement, and then the 2030 Agenda. These are very important global agreements. And then the financing part, the issue is only now walking our talk. It has to be implemented. Otherwise, we have the financing mechanism already, the Addis Ababa Action Agenda. So we need to really advocate so that financing mechanism is implemented, the 0.7% you said. And then when I come to WHO specifically, before actually talking about WHO's finance, I prefer to worry more about the big envelope, the money we need for the global health agenda. It's bigger than WHO, much, much bigger. And as Director General, I need to focus in really making sure that we have enough funding that can be channeled to countries used for the global health priorities that we have already agreed. So we need to focus on that. And that means we need to work with Global Fund, with Gavi, with other World Bank and others, and even new players could come. And then, of course, the domestic resource mobilization also, to have at least a fair amount of money in that big envelope. Then second comes the money we need for WHO. That one, one thing we should do is, first of all, we need to regain the confidence of member states, the confidence of stakeholders, partners, donors, and so on. That's very important. We need to show results, so people would be convinced to really put money in WHO. That we have already agreed and discussed many times, so we need to do that. And the second is, we're dependent on select countries or donors. We have to expand our donor base. It's like when a country gets into crisis because it depends on oil revenue only. So WHO should not depend on few countries or few donors. So expanding the donor base is important, and some countries I have engaged, or some partners, new donors I have engaged, are willing to come in to support. Then the third is, we have to really shift from earmarked funding to basket funding. So the WHO can have full ownership of what it's doing and finance its priorities based on its own priorities. The priorities should be financed by WHO once we agree on the priorities. Otherwise, earmarked funding is also, it's like a meddling for that matter. And really, WHO, we cannot say is owning its business. And then we have to strengthen the unit, the fundraising unit in WHO also. It's really weak, be it in terms of numbers of people working in that unit, and also in terms of the quality or the skill mix. It needs to really have a modern fundraising mechanisms using, modern techniques. So if we can have this comprehensive approach, I think we can address the challenges that WHO is facing. It has already a deficit shortfall for 2017 and even 2018 and 2019. And while I am still Director General-elect, I'm trying to explore how we can address that. But that will be my priority, especially after the orientation and so on, and some engagements with the directors and others. I have seen that finance will be a serious challenge. Thank you.
Thank you, Dr. Tedros, and that's why actually also being here on such a historic day where such a consensus for development that includes health is crafted can help move that agenda forward. I was hoping that Dr. Ala speak to us a little bit about the area we've not touched. We are sort of talking about countries with a reasonable amount of stability, let me say. But we have an increasing number of countries that are very fragile, that are in a war situation. We're facing the bombing of hospital facilities. You've been very engaged in the whole area of peace building, and of course we heard this morning also from Mrs. Margarini how the security policy, the issue of peace interacts with the issue of health and development. Would you share some of your experiences here and some of your thoughts?
For sure. I'm going to quickly talk about financing as well, though, just because I think we have to be a bit more blunt and honest. The money is there for universal health care. We have the money. I mean, the entirety of the Sustainable Development Goal agenda is an estimated $3 trillion a year. That's less than 3 to 4% of our global economy. And I know I, for one, would be willing to pay that for healthcare and education and climate change action and all of those things. So it's not that the money isn't there, it's that our governments are not prioritizing it. And it's that citizens need to start saying, listen, security to me means adequate healthcare, it means education for my children, it means living without the risk of poverty or ensuring that I won't go hungry. And that means that we have to start demanding that our money is not put in defense, military, surveillance, et cetera, but rather that it's focused on those foundations of a peaceful society. So the money is there, we just need to start moving it in the right direction. When it comes to conflict, I think it all stems to one key thing, which is the politicization of healthcare. And it's a very, very dangerous thing, but we do it very often. We do it particularly in conflict. We do it particularly when there's a crisis or when our government stands to benefit from politicizing a particular group. But it's a very risky thing. And I actually believe that it's probably the single most detrimental thing to healthcare. While health is a security and peace issue, it is. But that's secondary to the fact that it's just a basic human right. We should not have to have conversations about adequate healthcare and responsive healthcare and the bombing of hospitals and try to put it under the umbrella of security. It's just fundamentally wrong to bomb a hospital. It is a basic human right, and I don't think we need to continue to disguise these conversations so our politicians start paying attention. I think our politicians need to start paying attention to basic development, basic dignity, and basic human rights. And in absence of that, then I worry a lot more for the health agenda otherwise. Now, the last thing I'll say is during the time of colonialism, the general who colonized Morocco actually said that doctors were more effective than guns in placating and communicating with the people. And that's a very, very important message. That there is a power relationship in healthcare that I think we underappreciate in today's society. The recognition that doctors and nurses and midwives and pharmacists really are one of the most important relationships for a family and for a community, and that through them we can engage on a myriad of issues, some that are culturally and socially taboo, in ways that we can't engage through politicians or through, modern elected officials in a community. And so I think that we have to be, particularly in conflict societies, willing to say there are areas we will not move into, and there are areas where we have to take a stand, and that's first and foremost healthcare. That's the fact that when a hospital is bombed, we cannot simply invite the head of Doctors Without Borders to the White House and ask her to not talk about it. What we need to be doing is saying, yeah, no, we're going to talk about it. We're going to take a public stand. The WHO will stand behind them. The UN will have to start saying, listen, there are lines that we don't cross, and that's something we promised in the Geneva Convention that we failed to uphold. When we have threats of chemical attacks, the fact that we still have politicians which say it is the lesser of two evils to keep this head of state in power, I think is an insult, because the only person he is a lesser of two evils to are the people he is not bombing. And that says a lot about what you think of the life of the people within Syria or within that country. So if we're going to be honest about healthcare, if we're going to be honest about the impact and the efficacy of the WHO or of the Commission, we have to start being a lot more honest about the political responsibility. We are held accountable, and we should be held accountable because we've taken the responsibility for these people's lives. And if we're going to say chemical weapons are a non-negotiable, then we need to be able to stand behind that politically. And we need to ensure that our countries, be it in the EU or elsewhere, are willing to do that as well. Now, there's been a lot of talk today about the fact that the EU is doing very well. Yes, it has work to do, but there are other countries around the world that are the priority. And with all due respect, I mean, the treatment of refugees and migrants has been appalling. It's been appalling. I mean, in Libya today, there are camps where refugees and migrants are being abused and are effectively conducting slave labor that has been supported in part by EU negotiations and agreements. That's appalling. That is a violation of standard healthcare. And unless we start having those honest conversations, unless we start demanding more, not just for the people who look and sound and think like us, but for the people who genuinely need it, for people around the world in conflict societies, minorities, women and girls, then I don't think we're going to get very far. I mean, when we talk about girls' health and women's health, we miss a few of the key points, whereas we talk so much about climate change and what we need to do to combat climate change. What we really need to do is look at the practical thing, which is the education of girls and women's reproductive rights. That is the single most cost-effective practical solution to combat climate change. And in order for us to educate girls, we're then talking about sanitation. We're talking about infrastructure. And in order for us to have those honest conversations, we need to sit down with health ministries and say the bare minimum you can do to ensure long-term economic output and action on climate change is to have a bathroom in a school. There are practical solutions. It just means that we need new voices in the room. We need voices from the local communities to say, this is the challenge in my local community. It's not what you assume it is in Brussels. It's what we know it is to be. And we need those voices to help be architects of the projects, not projects which are formulated in Brussels or in New York or in Geneva, but rather projects which are formulated in that community, by that community, and for that community. If they're in conflict or not, they are the single best resource for what they need and how we can deliver it.
Thank you. Thank you, and that takes us straight to Kabbalah. You are one of those resources. What is your experience on the ground in terms of the fundamental areas and particularly the health promotion and prevention activities you try to do? How does that build communities? How does that involve people, let them participate? Does that contribute, to society overall?
First of all, I want to thank you, Dr. Ala Murabit. You said quite a lot of things that I also wanted to say in my address, but I'll just touch on it a little bit. In the project work that we're doing, we have noticed that there are quite a lot of people that might not be able to access healthcare because it's either too far or inaccessible, or they don't have the funds. So with our project, we take the healthcare services to the people. We go into their communities, we engage with their community leaders, as well as lobbying with private companies to actually help us do this work. And currently what we're doing as a preventative measure is promoting vaccination. Vaccination is quite important. We're running a measles campaign currently, as well as in the near future in August and September, we're going to be running a vaccine catch-up project, because if we prevent diseases in a community, and we vaccinate a child, we're not vaccinating just the child, we are protecting their family, we're protecting the schools in which the children are, we're also protecting a whole community. Not only does it combat infections, outbreaks amongst the vulnerable people, it also reduces our antibiotic consumption in the near future. We all know antibiotic resistance is currently the buzzword and what's happening. So if we vaccinate and promote vaccination campaigns, as well as go into our communities and make sure that every child is given the best possible start in preventing any diseases, and they can be on par with those people that actually can afford healthcare services, then we as healthcare professionals have done our part. If I were to put it in the context of young people, we also run, the first thing that comes to my mind is the HPV vaccine as a young woman, as well as for girls. Prevention, because they are sexually active at an early age. I'm sitting here today because somebody actually gave me the time of the day to promote, to provide me with a promotion campaign, as well as a health awareness campaign, to tell me that I can take my sexual reproductive health into my own hands, and I can protect myself, as well as educate myself about what I need to do to actually be a healthy human being and contribute to society as well as the economy. So if I can actually promote that in the rural areas as well, I will be paying it forward. So I just want to urge you as leaders within the health community to actually invest in vaccinations, as well as healthcare promotion projects and awareness campaigns, whether it be about HIV or communicable diseases or non-communicable diseases. As healthcare professionals, this is the best way that we at ground level can actually make a difference and provide universal health coverage to all. Thank you.
Thank you very much. Thank you. We've reached the end of our panel, and I've been told to be very, very punctual, and I'm a German living in Switzerland, so what else can I do but be punctual? I've been asked just to say a few words right at the end, and I think from what we've heard here from the panel, it's probably 4 Ps as well again. It's people that we've had, and But the issue of participation that we've heard in so many different ways, that it's not doing things to people, even through a deep humanitarian feeling and response, but really with people. And we also heard that this morning, I think it was even from your president, who said, you know, this is a conversation with, this is not something for. And that the SDGs bring a new level of equity into the discussion that is important. But the other two Ps that we've heard, and where we had a very strong plea to discuss them more openly, that is the two Ps of politics and power. And as long as we address these, as long as we don't address these as openly as we should, then many of the global health issues will not be resolved. And we have had the experience that actually in some areas, global health issues have become more difficult. You mentioned the refugee crises, and of course the situation, for example, of people in Mosul, etc., can only be addressed through very clear political action. And there is where the commitment of heads of government, of political alliances, becomes a very, very important one. So I believe if we keep this in mind, the politics, the power, the participation, and the people, that then maybe we can start a new type of global health dialogue that builds on health as a human right in a new dimension, because the fallback in some of the areas like humanitarian law and others is very disconcerting. And in a way, we will need to re-establish a consensus, another type of consensus globally, how important human life is and how important the life of people of both genders is, and even of other genders that are sometimes not named. So I hope that with that equity message and that political message, in a sense, from the panel, that also where we have had progress in health, it was due to political decision-making. It was due to priorities of the government. It was due to the willingness to move forward and to care for the poorest. And this is what we will have to take as our message if we're really going to be serious about leaving no one behind. Thank you very much to the panel for your messages, for being so outspoken, and thank you to you for having come to this session. Thank you very much.